Hi, good morning. My name is Lori Berard, and I work as a consultant in diabetes management and clinical research. And I'm from Winnipeg. And it is my great pleasure to be here with you today and to have been invited to share some knowledge about diabetes with this group of experts in cardiology and heart failure. Our worlds have collided. There's no question. We now have this, common theme that binds us in terms of medications that are used to manage diabetes, which are taking the world by storm. Whether you're a cardiologist or a nephrologist, everybody seems to be very excited about these medications. But let me tell you a little bit about what we think of them in the management of diabetes. So this is my disclosure slide. And I just want to point out that if I decide to discuss something that's not on label, it's based on evidence. So referencing to the clinical trials that have been done, or it's from the guidelines, and rarely is it my own opinion. So we had set out some learning objectives for you when the program was, the program invitation came to you. So there are 3 specific learning objectives. And from my portion today, I'm going to provide a basic overview of the use of Sglt2 inhibitors in diabetes. Nadia will go on and talk a little bit about the role of Sglt2 inhibitors in heart failure, and then provide you some practical tips and tricks around using these drugs in people with diabetes and heart failure. Not sure where that slide came from. Let's talk diabetes. So what do we need? Why is diabetes such an important conversation? Well, we know that it is an epidemic worldwide, that right now in Canada, at least 10% of our population lives with diabetes. And that is the people who've been diagnosed. We recognize that about 30% of people in Canada have some degree of dysglycemia, meaning that they have undiagnosed type 2 diabetes or they have prediabetes. And 3 out of 10, and this is huge because we recognize that individuals with prediabetes have the exact same risk of cardiovascular disease as someone who lives with type 2 diabetes. So these undiagnosed people are just, out there, and complications are occurring and they have no idea. And again, prediabetes, while we recognize it, we haven't done a really great job of treating it. And, what about diabetes? So, we recognize that it's been leads to many complications, micro or macrovascular. And as I explained to my patients, it's either your little vessels or your big vessels. But currently, according to the statistics from Diabetes Canada, released in 2019, diabetes contributes to 30% of strokes. It's the leading cause of new onset blindness in the adult working population. That we have 50% of people on dialysis have diabetes. And that 70% of non-traumatic lower limb amputations are from diabetes, which to me is a horrible statistic. We know that 1 in 4 people with diabetes will experience some sort of a foot ulcer in their life. And I guess it just really calls out that we don't do a great job of talking to people with diabetes about their feet or checking their feet, that we have such a high rate of moving from, some sort of trauma to their feet to having an amputation. And so this statistic hasn't changed in my 30 years of diabetes. And last but not least, 40% of heart attacks are related to diabetes. Now, this is actually an improvement. When I started working in diabetes in 1987, we used to say 80% of our patients will die of a vascular event. So I think from, all the work that's been done in the area of vascular protection with statins and aspirins and all the other fancy medications that we can use, and all the interventions that have been developed, that we are doing a much better job of keeping our patients alive with diabetes. However, when I was preparing for this talk on the 9th of December, you can see that there was a tweet that came out that day from the World Health Organization that death from diabetes increased by 70% globally between 2000 and 2019. And diabetes has now entered for the first time ever the list of top 10 causes of death. So to me, this is a call to action because we recognize it's not diabetes that causes death or complications. It's uncontrolled diabetes that leads to the issues. So what do we do? So again, I come from a diabetes background. We are still very glucose-centric in the Diabetes Canada clinical practice guidelines because not everybody that lives with diabetes is also living with all of these multiple complications. We realize that early control matters, and what we do today in the beginning of diagnosis will change their outcome in the long run. There's been great work that tells us that. We know that we need to target an A1C of less than 7%. Blood pressures for our patients are 130/80. LDL targets are less than 2. We have talked a lot about drugs to protect the heart in the past. So we've talked about ACEs and ARBs and statins and aspirins if indicated. But we now have expanded that as recently as October this year to talk about drugs for cardiorenal protection, and that's for the Sglt2 class and as well our GLP-1 receptor class falls. So I'm going to talk a little bit about that later. Our E's are exercise goals and healthy eating, screening for complications, smoking cessation, self-management, stress, and other barriers. Now, we used to, in the 2018 clinical practice guidelines, we had, in the 2013 clinical practice guidelines, we said, the ABCDEs of vascular protection, but actually this is the ABCDESs of diabetes care in general. So yes, there are certainly call outs here in terms of vascular protection, but this is the roadmap that all people living with diabetes should be on in terms of their diabetes care. And that's what we should be following and promoting. And we do that through our evidence-based clinical practice guidelines. And just a call out that there's a lot of really great resources on guidelines.diabetes.ca to help you and your patients understand some of the self-management issues, about some of the things around, healthy eating and exercise, and patient information about screening for complications. So this is the type of work that we do in diabetes care in a big overview. But again, we are still somewhat glucose-centric because when you're newly diagnosed with diabetes, you may have some complications present, but at the end of the day, while we know it's the macrovascular complications that really cause, morbidity and mortality for our patients, the microvascular complications really change the quality of their life. It also, of course, changes morbidity and mortality as well, but it's people live with diabetes for a long time, and if we don't look after glucose, we will see the incidence of the microvascular complications. So glucose-centric to a point, glucose really does matter. It is what leads to these complications. And I've been in diabetes for a really long time, and we didn't have a lot of great medications in the 80s when I started, and it stayed that way for almost 20 years, that we really didn't get any new tools in the toolbox. We were using metformin, we were using some form of sulfonylurea, and we were using human insulins. And then the world really changed, and we got access to newer medications. And with newer medications available to lower glucose, we could start talking about this new composite endpoint, which is we still want to reduce hyperglycemia, but we want to do that without causing weight gain, and we don't want to increase hypoglycemia. Both weight gain and hypoglycemia carry serious consequences for our patients. And also, we just recognize that, not being able to achieve good glucose control without these problems really just is so detrimental to people in terms of their overall management, but also their burden of care. They really want to get better, but they don't want to gain weight, and they don't want to experience hypoglycemia. So as I mentioned, we saw a lot of changes in terms of what came into our diabetes toolbox. When I started back in the late 80s, we used to say that diabetes was really the fault, the type 2 diabetes was really the fault of the person. If they ate better, if they exercised more, if they lost weight, they could cure their diabetes. We really didn't understand that, in fact, there are at least 8 mechanisms that come to play in terms of why diabetes occurs, why type 2 diabetes occurs. So things like decreased insulin secretion, we know a lot now about the incretins, the role of glucagon, the increased lipolysis, the increased hepatic glucose output, the role of the brain in terms of neurotransmitter dysfunction, and the insulin resistance and decreased glucose uptake. But if somebody told me 20 years ago or 30 years ago that I would be talking about the role of the kidney in terms of glucose regulation, I would have said, no, the kidney, like what does the kidney have to do with diabetes? But in fact, we've learned an awful lot, not only about what it has to do with diabetes, but what the mechanism in this kidney is able to change in terms of cardiorenal benefits with the Sglt2 inhibitors. So more about that. But we do really have two other new classes. So we talk about the GLP-1 receptor agonists, and we also talk about Dpp4 inhibitors and Sglt2 inhibitors. Thiazolidinediones made an entrance in the mid-90s. They made an exit in the early 2000s. They are still available, but rarely used due to some risk of some thoughts that there was risk of cardiovascular harm, macular edema, and there was a black box warning from FDA, which has been lifted now, but basically these drugs have fallen out of favor. There is some newer evidence around stroke prevention in non-diabetes patients, but again, in terms of general diabetes management, you don't see these drugs used often. But we're really here today because of an apple tree. You're like, Lori, like an apple tree. Well, the first Sglt2 inhibitor that was developed many years ago and abandoned was developed from the bark of an apple tree. So thank you to the bark of an apple tree. We have moved on to now actually have successful Sglt2 inhibitors on the market. So lots of things about how these drugs work, but basically at the end of the day, everything happens here in the kidney primarily. Sglt2 is primarily in the proximal tubule of the kidney. So what happens is someone has diabetes. We know they have excessive glucose. It hits the glomerulus. We'd like to filter it out and pee it out. However, there's an upregulation of the renal threshold in people with type 2 diabetes, where you and I would normally pee out any excess glucose over 11 millimoles per liter. Their renal threshold goes up. They hold it all in until they're very hyperglycemic, so consistently have glucoses over 14, and then they start to have glucose in the urine. So when we add on an Sglt2 inhibitor, it blocks the Sglt2 receptor in the proximal tubule, and what ends up happening is that the glucose that was being reabsorbed previously starts to be excreted. The renal threshold drops to 5, and our patients excrete between 60 and 100 grams of glucose a day, and that equates to a little bit of weight loss because they're losing, up to 400 calories a day. And it equates to some blood pressure control because they're taking fluid with that as well. And so for our patients, this is a mechanism that originally when someone said, we're going to do this, I was like, wow, in the patient's kidney, like we can't harm the patient's kidney. It would be terrible. But in terms of glucose management, this has become a very interesting phenomena that people are still kind of like, I thought sugar in the urine was bad. But in fact, when we use Sglt2 inhibitors, peeing out that extra glucose really has a lot of benefits for our patients. So that's just a very rudimentary description in terms of how we like it for diabetes. I know Nadia is going to talk a little bit about the theories of how it works in terms of that cardiorenal benefit, because the magic really does occur just in the kidney. There doesn't seem to be a lot of receptors anywhere else, although more research is going on in that as well. So we like them because as a class, you can see that there's an A1C reduction of anywhere from 0.6 to 1.1. Canagliflozin is in the blue, dapagliflozin is yellow, empagliflozin is gray. And what's really important about this slide is regardless of the background therapy, so no background therapy, metformin on top of sulfonylurea, on top of metformin and sulfonylurea, and on top of insulin, you still see an A1C reduction. And these are some pretty significant reductions in that this is often the second or third medication added to someone with diabetes. Insulin independent action, which means across the continuum of diabetes, these medications will work. You do not have to have robust pancreatic function. You are not tapping on the pancreas to put out more insulin. You are reducing the glucose load. So the pancreas actually has to work less in terms of insulin production to manage that. We also are very excited about the weight loss that we've seen in the clinical trials, and it's anywhere from 2 to 3 kilos, which may not sound like a lot, but guess what? Especially in an insulin-using patient, we know that when you add insulin to a patient, they typically put on at least 2 kilos. So when someone's on insulin and they decrease their A1C by about 1% and they lose 2 kilos, that is success on all levels, because that's not what typically happens for our patients. On the background of SUs as well, these medications tend to lead to weight gain, and you can see here about a 2 kilo weight loss, and then of course metformin and monotherapy. And last but not least, hypoglycemia. So I mentioned we want to lower glucose. We want to not increase weight, and decreasing it is amazing. And we don't want to increase hypoglycemia. So used alone, these agents have no reason to cause hypoglycemia. On the background of insulin or on a sulfonylurea, of course, it's the background therapy. So as glucose has become more in target with the Sglt2 inhibitors, the risk of hypoglycemia will go up. So, and this is an average baseline of 8%, so dropping by 1% to a target range of less than 7. So with that in mind, I mentioned, and again, this is just a very brief Diabetes 101. I could spend hours and hours and hours telling you about how amazing all of these new medications are for a variety of reasons. But we have three new agents that came into the class, three new classes of agents that came into our toolbox: Dpp4 inhibitors, so similar to SUs in terms of A1C reduction, no blood pressure, no impact on weight, rare hypoglycemia. We are very excited about the GLP-1 receptor agonists. And you can see, again, lots of glucose lowering. This is about 1.5% for an A1C. Blood pressure reduction is slight, a decrease in weight, but that too is a lecture for another time. But over here are Sglt2 inhibitors. So as a class, we see 1 to 1.5% reduction in A1C. Depending on the literature, it can be anywhere from 0.6 to 2. It also depends on how high their A1C is when they get initiated. So the higher the A1C, the more robust the lowering. Blood pressure reduction has been an added bonus for our patients, many of whom are not at target, impact at weight, and rare hypoglycemia. So for that, we are embracing this. Diabetes still needs to be managed in terms of glucose control, and this has been a welcome addition into our class, into our toolbox. As a research person, I started working on Sglt2 inhibitors in 2001. And they finally hit the market for us in 2014. It was like birthing a teenager. And there still is a lot of confusion, skepticism, and lack of understanding about how these agents actually work. People think that they're harder to prescribe because you need to counsel around things like genital infections, which are actually usually fairly easy to treat, one and done. There is no signal for an increase in urinary tract infections, although has been reported in the early literature. We have had some signalings of safety about AKI, and in fact, it is better in terms of reducing acute kidney injury. And then there was a niggling little doubt about the potential for an increase in amputations with canagliflozin. However, the Credence trial has shown that in the highest risk population that there is no increase in amputation. So everybody feels very confident with that it was a one trial, just one of those things that happens. Sometimes it does. And that the risk of amputation in high-risk patients is always there. And it reminds us we need to do good foot care. Okay, so how did we get to being together today? Well, I'm not sure if you knew that after the thiazolidine-dion story, where there was this bad meta-analysis done by Steve Nissen, there was the thought that perhaps rosiglitazone increased harm in terms of increasing myocardial infarctions. So the FDA decided that it's great that you show us this amazing efficacy data on all your new diabetes drugs, but how do we know they're not actually going to hurt your patients? So in 2008, they came up with a guidance document that said every new diabetes drug had to do a large, long, huge cardiovascular outcome trial to prove that they were not harmful. So, again, we embarked on that with Dpp4 inhibitors, with insulin, with Sglt2 inhibitors, with GLP-1 receptor agonists. And the first few of these trials, so the earliest ones were done in Dpp4 inhibitors. And the first GLP-1 was examined. And, nothing was exciting here. Like, it was like, yeah, they're safe. Okay, carry on. So hundreds of thousands of patients, actually, and, millions of dollars to say, yeah, they're safe. But then, we started to see other trials being done. So EMPA-REG, LEADER SUSTAIN. So this is sort of the more recent trials. And a really interesting thing was a funny thing happened on the way to safe. All the FDA asked us to do was show that these drugs were safe. Well, not only were they safe, but with our two classes, so Dpp4 inhibitors have always been non-inferior, no harm, no benefit. With the exception of this little niggling thing about heart failure with saxagliptin in the SAVOR trial. But when it came to the Sglt2 inhibitors, when they started presenting their results, this was our game changer. We had never seen this. When EMPA-REG was announced in 2015, and it showed a 14% reduction in MACE, the entire audience stood up for a standing ovation, and almost a 40% reduction in CV death. Now, each of these endpoints to get the MACE kind of came from different things, whether it was, CV death, non-fatal MI, non-fatal stroke. But at the end of the day, something was benefiting our patients. So we have 2 with the Sglt2 inhibitors. We know that DECLARE was a primary prevention study with 2 co-primary endpoints. And so they didn't reach statistical significance for MACE. They had a co-primary endpoint for CV death and reduction in hospitalization for heart failure with a 17% reduction. But what really started to catch the attention of the world was, what the heck is this over here, this reduction in hospitalization for heart failure? Baseline, they had like 10% of people had heart failure as a known diagnosis at baseline, but this is a huge reduction. And why is that occurring? And why in this group of patients? And these were secondary outcomes, as was the renal outcomes. And it was, again, the same thing. It was like, what's going on here? There's a 46% reduction of composite renal endpoints. There's a 40% reduction. There's a 47% reduction. And there's all this positive signal in the renal world. Now, again, we saw that with GLP-1s, mostly in the MACE, and I don't have time to go into that today, but all of these CVOTs have changed the way we manage diabetes. Cardiorenal benefit. Now, we did also get some dedicated renal trials, just like Nadia is going to talk about the dedicated heart failure trials. So instead of using the population from these large CVOTs, which were pretty much mild CKD, they were, their eGFRs were fairly decent. They were microalbuminuric. In the Credence and Dpp4 trial, they enrolled the most high-risk patients. So the patients with significantly elevated albumin-creatinine ratio, they were macroalbuminuric and they had low eGFRs. These are really sick kidney patients. On the kidney risk factor equation, they were considered high risk. Patients that were really declining. And you can see that in that population, there was a significant reduction in the composite endpoints, 30% with Credence, 39% with Dpp4 and that both those trials were stopped early for overwhelming efficacy. And that's amazing when that happens. And what's really important is in the Dpp4 trial, they had it in people with and without diabetes, they saw the same benefit. And there was a significant number of people without diabetes. So this is game changing for nephrologists who've been waiting for like 17 years or 18 years for a new therapy since ACEs and Rs in the management. And they also, in this high risk population, showed benefit in terms of CV death and hospitalization for heart failure. So we have something that's real here. And as a result of that, our Diabetes Canada guidelines have updated because we do follow the evidence and we do want to incorporate this. So this is our basic guideline. This is what we do at diagnosis. We assess now for cardiovascular and renal status because it needs to become part of what we think about. And then this is how we treat patients. So again, at the beginning, you can start metformin plus or minus, another agent if their A1C is 1.5% above target. But the bottom line is that if they're not at target or there's a change in clinical status, there's a call to adjust therapy. So this side is about glucose lowering. And of course, I've just sort of talked about that, reducing weight, not increasing reducing A1C, not increasing weight or hypoglycemia. But this side is our magic. This is our what's changed significantly. And there's a really strong message here. So if someone at diagnosis has cardiorenal disease, such as established cardiovascular disease, chronic kidney disease, or heart failure, they meet this population of patients. And we know that based on the large cardiovascular outcome trials, that this population of patients benefits with different agents, whether it's to reduce MACE, reduce hospitalization for heart failure, or progression for nephropathy. So irrespective of A1C, we are saying you need to add or substitute an anti-hyperglycemic agent with demonstrated CV benefit. Metformin is still our first line, and it will stay our first line for a whole variety of reasons. But if you had someone with a previous MI, you could make a decision to start them on either a GLP-1 or an Sglt2 inhibitor for MACE. If you have someone who at diagnosis has diabetes and a known background of heart failure, you should be putting them on an Sglt2 inhibitor, irrespective of their A1C. And then again, no time to really go into this primary prevention with a GLP-1 receptor agonist, but there is evidence for primary prevention in older people with 2 risk factors. Good idea and consensus for progression of nephropathy. So our evidence is at the bottom, and you can see we have grade A level 1 evidence for the management of diabetes and the reduction of risk for hospitalization for heart failure. and all these other outcomes. So we have updated our guidelines to do this, to be able to demonstrate that we are recognizing when people have cardiorenal disease and that we're establishing the best glucose therapy for them. Remember though, it's only about 20% of our population that actually would fit the inclusion criteria for any of these trials. So we still need to manage glucose on the other side. So what do I want to say about all of this? So this was just a very high level overview of sort of diabetes, where we're at, how we got there. But diabetes and heart failure, I think a lot of us have talked about it over the years, but we've never really paid a lot of attention to it. We've heard, endocrinologists say, I don't have heart failure patients in my trials. And I have a friend who's an endocrinologist who's married to a cardiologist. And she goes, well, I actually see a lot. And the other one says to her, well, that's because you're married to a cardiologist. But we recognize that it's actually a very common complication in diabetes, which has not been addressed for many, many years. So a higher risk of heart failure, primarily more so in women than men. There's an incidence of hospitalization for heart failure is higher than that of a non-fatal MI or non-fatal stroke. It's also the leading cause of cardiovascular mortality. We know that there's an increase with the post-MI event, but then there's also modeling issues, and the response to therapy is the same. We know that our patients have a higher risk as they get older, more so than the general population. We also understand that it's the mechanism of, dysglycemia that accelerates coronary atherosclerosis. We often have our patients having hypertension as part of their metabolic syndrome. There's the development from glycation in terms of myocardial fibrosis. And so we have all of these things that happen because these people have underlying diabetes, which puts them at risk. Now, the other thing, so this is some work that's been done by Jay Udell, and Jay showed very clearly when he did this paper that for our patients that are rarely controlled to target, that's the other issue is that the mean A1C in this country is likely closer to 9% than it is to 7%. And every 1% of increase of A1C increases the risk of heart failure by 8%. And if we had a mean A1C in this country of 8.5, you can see how the increase of risk of heart failure. And then he had done some original work looking at our big cardiovascular outcome trials and their effect on weight. And he also helped us to understand that the other reason we need to avoid weight gain in our patients is because for every 1 kilo change in weight, the risk of heart failure goes up by 6%. So these are the cardiovascular outcome trials that were done in diabetes. And these are the agents that cause weight loss. And you can see there was less incidence of heart failure. These are drugs that cause weight gain, and you can see the increased risk of heart failure. And then drugs like insulin in the Origin trial or Devote, really they can be managed in terms of weight gain, but certainly the agents like the thiazolidinediones, which we know cause a significant amount of weight in the DREAM trial, RECORD trial, PROACTIVE, ADOPT. These are trials that indicate that these agents will increase the risk of heart failure because of I shouldn't say the agents do, it's the weight gain that does. So we've learned an awful lot about, the relationship between diabetes and heart failure. And I think it's a call to action for people in the diabetes world that we really need to think about this in our patients. And a lot of our patients have underlying undiagnosed heart failure, which brings me to the last slide I have for you, which is I just want to remind you that heart failure is a frequent, forgotten, and often fatal complication of diabetes. And this is a paper from 2003. And I think now there has just been a realization of how much heart failure our patients actually have and how we can better manage them to give them a better quality of life in terms of not only managing glucose control, but reducing the risk of these cardiorenal, reducing the risk of cardiorenal endpoints. So with that, I'm going to stop and I'm going to let Nadia take over.